alignment of the spine. So instead of having a nice lordotic curve, you end up having a reverse curve due to things progressively over time. This can also lead to things like significant degenerative joint disease that prolonged postural changes over time can lead to things like anterior listhesis or spondylolisthesis, especially in the low back. These are all elements of compensatory changes from instability. These visible misalignments and gross degenerative changes can be seen on x-rays, right? Our spondylolisthesis, our anterior or retrolisthesis, like I said, disc height changes, our George's line on x-ray is now altered, so we can't, or so we're leading towards reverse type curves. In addition, MRs can show signal intensity for the changes in the bone marrow and just our articular surfaces that can be associated with degenerative disc disease as well. Elements of instability, we already made note of this. We can have poor adaptation or compensation just in our standing postures. We think about our head forward posture, compensating by getting rid of our lumbar lordotic curve when we're standing. Dr. Morgenthau probably put this on here for me, computer praying mantis posture, leaning forward like this. So all those things progressively over time can lead to joint dysfunction. We're skimming through that because we went over that through mechanics. Other elements of traumatic instability, we can have our acceleration or deceleration mechanism, our coup contra coup. This is talking about our whiplash. Different types of x-rays can show us aberrant motion or changes in motion. I'm thinking about flexion and extension x-rays where you can see that translation of different vertebrae leading to elements of instability or a diagnosis of instability. Or post-traumatic spondylosis, even progressively post-trauma, if something like a traumatic spondylolisthesis doesn't get caught or seen, leading to some sort of spondylosis even post-trauma years down the line. Disc degeneration can also impact our instability. We're getting decreased vascularization, can lead to bony overgrowth, leading to disruption in our motion. We have proteoglycan degradation, so lack of lubrication of our joints. And Stuart McGill is quoted as saying that discs only have so many numbers of bends before they damage, right? We can withstand a significant amount of pressure and compressive loads, but repetitive things over time end up taking their toll in regards to disc degeneration. Different types of arthritides or arthritises can also lead to progressive instability. Rheumatoid arthritis, Reiter syndrome, ankylosing spondylitis as well. We mentioned these phases of our Kirkcaldy-Willis, levels of degeneration. It particularly has those 3 phases, but our Sandoz model has 4. We're not going to go over them too in detail. But both of these models agree that that second phase is due to repetitive mechanical overstress to the discs and the surrounding structures. So although we have different models per se, we can both agree that that progressive overload over time within those second phases lead to compensation for bony overgrowth, restricting our motion, things of that nature. The difficulty comes with intra-professional reliability of identification of joint dysfunction. Some chiropractors really value radiographs and x-ray findings. Totally fine. But the issue here is that interprofessional reliability is difficult because identifying those different subluxations or joint dysfunctions suffers from conflicting evidence regarding its validity, despite growing evidence that supports our ability to reliably detect and report. So there are conflicting results in regards to accurately palpating, combining that with x-ray findings. Even though we do have increased reliability from research showing intra-professional consistencies. And what I mean by that is I can palpate L1 through L5 and I find the same restriction that 3 other chiropractors would find. That reliability of our palpation skills, which is why they're so important and why we kind of dial that in with you guys in those first terms, right? You need to be able to be specific in those palpations to increase our interprofessional reliability in order to validate that type of detecting. And this is why research is important, right? To increase the reliability, increase the validity of said diagnostic palpation, as well as x-rays and radiographs that we choose to utilize. It's controversial, especially for patients without pain. Because remember, we talked about how joint dysfunction can be present even if someone's not experiencing pain. We know from a scientific standpoint, not the rollover, but the downward spiral and cyclical pattern we can get into if we don't address these types of joint dysfunctions. But it's a controversial approach because some also agree that, oh, well, there's no pain. How do you know that that's restricted? And how can you be so sure? So until further research, that's unfortunately kind of like this middle ground and where